Hi, everyone. We're very grateful to have Professor Megyesi with us today, delivering her November keynote at Campsign. We're very honored to have him. He is a really big leader at Western and within Canada. He received his medical degree at Western back in 1985, where he also pursues a master's in biochemistry. He then completed his residency at University of Alberta in Edmonton with a PhD in experimental surgery. And he then joined the faculty of Western in 1998 with a special interest in neurosurgical oncology. He holds various positions of leadership, including the chairman of the Scientific Program Committee of the Canadian Neurological Sciences Foundation, and he sits on a number of very important committees, including the Royal College of Physician Surgeons of Canada. So we're very glad that he could join us today and impart his wisdom to the group. Dr. Megyesi, the floor is yours.
Okay, well, thanks very much for having me give this presentation. And I understand that you're all keen on neurosurgery, so I will give you some insights into my experience with neurosurgery, I guess my career and different decisions I guess I made during that career, and some good, some maybe not as good as they might have been. And I'll do that kind of through the lens of what I do in my day job, which is generally operate on patients with brain tumors. Now let's see if this is going to thought it was working, but maybe not. Now it's frozen. Okay, do you see that? Disclosures.
Yes, we can see it.
Okay, I think we're in business. So as was said, I've done various things. I've been the past chair of the board of the directors of the Brain Tumor Foundation. I've started a small company with individuals there, and I'll show you the online tool that we've developed a little bit later. But really, none of those things have conflict with this presentation. I'd also like to acknowledge a number of individuals before I even start. I think you've had Dr. Del Mastro as one of your speakers in the past. He had a fair bit of influence on my career. I was always, as a medical student, I was always interested in surgery, I think. But I was more interested in general surgery when I was at, second, third, fourth year. And I spent some time with Dr. Del Maestro doing some research, and got more interested in neurosurgery because of that. I think I always had a research interest, but spending time with him kind of showed me that neurosurgery was not only an interesting specialty, but had options, maybe more options than general surgery. Now, I think that changed as the years went by. I mean, when I was going through transplantation, was sort of early. It was kind of in its infancy, and I think a lot of research opportunities came about with transplant people. So Dr. Del Maestro and I have remained close, maybe not in the last few years because he moved to Montreal several years ago, but we also are both involved with the Brain Tumor Foundation of Canada. He was one of the co-founders, and as I said, I was one of the chairs, and so that relationship has always been strong. And we'll talk a little bit about mentorship later on. I can say that Dr. Del Maestro was one of my mentors. Another person I'd like to mention is Dr. David McDonald. He's not a neurosurgeon. He's a neurologist and neuro-oncologist. He recently retired. He's very well known in the Canadian neuro-oncology world. He's an excellent clinician, but was also involved with a number of trials that led to some of the breakthroughs in neuro-oncology. One of the trials he did was with another oncologist by the name of Greg Cairncross, and they were the first ones to show that 1p19q co-deletion was sort of a signature for oligodendroglioma. We live in a very highly molecular world now, but at that time, about 20 or so years ago, molecular biology was not nearly as prominent as it is now, and McDonald and Cairncross, were two of the first individuals, along with the neuropathologist David Lewis in Boston, to sort of break into that area. He's also become a very good friend. I think this is an example of how two different specialties, neurology, neuro-oncology, and neurosurgery, can work together. I think you'll find that in your career, collaborating and working with people is maybe as important as anything. Obviously knowledge and skill are required, but you need to be able to work with people. And because I was able to work well with Dr. McDonald, that certainly helped my career. That's a picture of him at his cottage, which I've gone to a number of times over the years. It's just north of Toronto, near Algonquin Park. And the picture on the right is him and I climbing Mount Kilimanjaro. That was about 10, 15 years ago now. And I made it to the top. He didn't quite make it, but he had good judgment. He felt he was just not quite able to do that. The third person I'll mention, I never met, Dr. Richard, a neurosurgeon, researcher, teacher, mentor, pilot, golfer, farmer, family man. I researched all this. And the reason I'm giving you this talk is probably because I was recently the Richard visiting professor in Ottawa. And I think that was where one of your colleagues saw me giving this talk and thought that you guys might also find it of interest. So the objectives I will try to make for you here are, I will try to identify key milestones that led to the development of surgical neuro-oncology as a specialty, describe current concepts in the surgical management of neuro-oncology patients, gain an understanding of potential future modalities that might be helpful in the surgical treatment of neuro-oncology patients. Dr. Del Maestro, who I mentioned at first, is actually quite involved with the history of medicine, as well as Leonardo da Vinci. Those are two of his passions. And Dr. Del Maestro actually produced a small book on the history of neuro-oncology. And some of the images that I'm going to use are from that book. So I wanted to also acknowledge him for that reason. I've also had an interest in the history of medicine over the years. So as I said, I will emphasize surgical neuro-oncology in this presentation, but I will also refer to some general neuro-oncology concepts. So we'll try to divide it into 3 bits: the past, the present, and the future. And obviously, to be competent in surgery, you have to have a basis for that. And probably the most important thing that you guys need to know once you become neurosurgeons is the anatomy. Anatomy is not really that, knowledge of anatomy is not really that old. Andrus Vesalius, and you can see there the years that he was alive, was one of the first individuals to perform accurate dissection of human cadavers. Prior to that time, dissection was frowned upon. And I think he would actually go into graveyards and get some cadavers in a clandestine manner. But nevertheless, he got them, and he did some very accurate dissections of the cadavers. And this knowledge of anatomy is really the foundational basis for surgery. So when you get into neurosurgery, you definitely need to review the neuroanatomy texts, and not just the tracts and the sort of brain anatomy itself, but you also need to become familiar with what we call surgical anatomy. Generally, you're operating, from outside in, and especially if you're doing vascular work, you need to know the blood vessels that surround the brain. You need to know their relationships, and so forth. So you need to know neuroanatomy as well as surgical anatomy. Now, we really can't do surgery without anesthesia. And I would make an argument that when you're in neurosurgery, you need to work very closely with the anesthesia folks. Some centers have devoted or dedicated neuroanesthesia. Others, the general anesthesiologist will also do some neuro cases. So it behooves you to get to know them. But what is the origin of anesthesia? So William Morton and John Warren are the names to remember. And the first use of an anesthetic was sulfuric ether at the Massachusetts General Hospital in Boston in 1846. This work was published in the Boston Medical and Surgical Journal by Henry Jacob Bigelow, who was a surgeon present at the operation. The operation took place in what they now call the Ether Dome at the Mass General. And when I was doing my fellowship in Boston, I went over to the Mass General because I was very curious to see what the Ether Dome looked like. And at that time, security wasn't that great, so you could kind of get into the hospital and wander around the hallways, and nobody really looked at you, frowned upon you. So I found my way up to the Ether Dome, and to my disappointment, it's used for storage now. So this beautiful area, which I have a nice painting of, is now filled with boxes. But that's the way things go. But it's still there. The third thing that's obviously important is infection. And when you guys become residents, you will always fret about infections in your patients, as will your staff. We obviously have pretty good ability to control infection now, and this stems from an individual, Joseph Lister. We can see the years that he was alive there. And he did lab work, and he applied this on the clinical ward. And aseptic techniques used today find their origin in these clouds of carbonic acid initiated by Lister. And the other individual who I didn't mention here is Ignaz Semmelweis, who worked in Hungary, and he was a very strong advocate of using aseptic technique on the maternity ward. And infant mortality was very high, but after he impressed upon the obstetricians that they should try to use more aseptic technique, this improved infant mortality greatly. So Lister and Semmelweis are really the two names in the control of infection. Now, what about operating on the brain? There is some uncertainty as to which was the first true brain tumor operation, but it may have been this one in 1884. The patient was a 25-year-old male farmer presented with a focal motor seizure, and this was in London, England. And the physician was Alexander Bennett. And the diagnosis by Bennett was encephalic growth, probably of limited size, involving the cortex of the brain and sitting in the middle part of the fissure of Orlando. So this was determined without any imaging. Surgery was recommended by that physician and was performed by the surgeon, Godley, at the National Hospital for Epilepsy and Paralysis, using aseptic technique. No image guidance at that time, so localization was by external coordinates. The skull was trephined, the dura was opened, but no tumor could be seen. So they weren't really sure they were on the lesion. The cortex was opened cautiously, and after some exploration, they removed what they thought was a tumor, and probably was a glioma. Unfortunately, despite using aseptic technique, the patient died of meningitis 1 month later. But still, not too bad for localization on the neurologic history and exam and external coordinate localization. Now, what is the foundation of modern surgery, the surgical team? Because once you guys become neurosurgeons, you will find that the surgical team or the neurosurgical team is essential. And of course, that's made up of the surgeon, the anesthesia folks, the nurses that you have in the operating room with you, and it goes beyond that. It goes to the people that clean the equipment. It goes to people that book the ORs. Everybody has a role, and everybody's important in their own way. Obviously, it's important for you as the surgeon to be competent, but things only work if you have a team that works well together. So Halstead is the name to remember for this. He was the first professor of surgery at Johns Hopkins Hospital and Medical School. He was a meticulous surgeon, especially in the control of bleeding. And he really was the first to advocate for a surgical team. In fact, he went so far as to marry his scrub nurse. I don't know if you guys need to do that, but that was an interesting note. Now, what about neurosurgery as a subspecialty? So the credit generally goes to Harvey Cushing for this at the end of the 1800s. Clearly, he's a leading figure in the history of neurosurgery, and one of the first surgeons to devote himself completely to the field of neurosurgery. And he also was a Boston person, worked at Harvard. He was a very good collaborator. He improved hemostatic techniques, the so-called silver clip, and along with a physicist at Harvard, he developed electrocautery, or they developed electrocautery. And the name of that person is Bovie, and the instrument is still often referred to as a Bovie. So when you're in the operating room, and some of you have probably already been in there and been involved with cases, you have what's called bipolar cautery, and you have what I call unipolar cautery, or people refer to it as the Bovie, and it's quite good for doing the initial opening. Not so much intraoperatively now; that's pretty much been replaced by the bipolar cautery. But you can see the historical collaboration there between surgeon and physicist. Cushing was also meticulous at documenting his work and keeping track of the number of cases that he had done. He did 2,023 verified brain tumor operations, as well as quite a number of unverified operations. He was quite expert in pituitary tumors, 360 pituitary tumors, 271 meningiomas, acoustic neuromas, metastasis, and gliomas. An interesting breakdown. That would probably not, things would probably not break down like that for a single surgeon now, unless they were just basically a pituitary specialist. Cushing was also one of the first people to try and classify brain tumors. And once again, he did this in a collaborative manner with the pathologist Percival Bailey. And they developed this classification system that still is referred to today. I mean, as I said earlier, molecular biology is replacing the histologic diagnosis of tumors, but the origin is still back in this original work by Cushing and Bailey. And the U.S. government honored Cushing with a stamp, I don't know, 20, 30 years ago. I have one of those in my wallet, if you can believe it. Now, what about understanding brain function? So that stems back to this individual, David Ferrier, medical school in Edinburgh. He worked with primates, and in primates identified the motor area, the area of vision in the occipital lobe. And this work was carried on by another one of our Canadian colleagues, or heroes, I guess, Wilder Penfield, in the 1900s. As you guys, I'm sure, know, Penfield worked at the Montreal Neurologic Institute and Hospital, and he was really one of the first to develop the concept of cortical stimulation and the use of awake craniotomy for brain tumor surgery. And many centers, of course, now do lots of their cases, epilepsy cases, awake, and eloquent brain tumor surgeries awake. Now, another area that I'm particularly interested in is stereotactic surgery. You can see the origins there. The name that you will often see is Lars Leksell from Sweden. And this is the development of a stereotactic apparatus in which the target is always centered. So this is often referred to as frame-based surgery. I generally use it for brain biopsy, but it's also used for the delivery of radiation. And Leksell was involved with the development of the Gamma Knife. Really, the proper term is radiosurgery, but I think Leksell was pretty good at marketing too, because using the term knife is a way to get people listening, and the name has stuck all these years. When you start getting into operating, you will also see now what's called frameless stereotaxy. It's just a fancy word for not using a 4-point fixated frame on a patient's head. Instead, you put them in 3-point fixation and use the image guidance device in conjunction with a kind of an arm. It's kind of clever terminology for essentially doing what a frame-based procedure does. And some argue that frame-based is actually still more accurate. But you will see surgeons using both techniques now, frame-based and frameless. So another major advance for neurosurgery in general, in neuro-oncologic surgery, but especially for aneurysm surgery at the time, was the development of the operating microscope. A lot of the credit goes to Dr. Yassergil for this. He was a surgeon originally from Turkey, but did a lot of work in Switzerland. And he was involved with the development of the counterbalanced operating microscope. And this allows us to do microsurgery. Another big advantage of the microscope is it gives you a lot more light. A lot of times when you're doing neurosurgical procedures, you're working in a fairly deep hole, whether it's a tumor resection or an aneurysm clipping. To have light get down that far is very, very helpful. And that's where the microscope, as well as the magnification, the light, both of them are important. This was adopted quite early by surgeons such as Charles Drake in London, Ontario, where I am, and I think for his excellent surgical technique and for his involvement in the development of the operating microscope, Yassergil was named the neurosurgical man of the century for 1950. Half century, I guess, 1950 to 1999, with Charles Drake as the runner-up. Now, this isn't neurosurgery specifically, but brain imaging, of course, has revolutionized treatment of neurologic disease. And this goes back to the original CT scanner, and this is developed by Hounsfield. You can see the years that he lived there. He worked with a company called EMI in Britain, and they developed the CT scanner. And for this achievement, he was given a Nobel Prize in 1979 and was knighted in 1981. And you will still hear, of course, when the neuroradiologists talk about intensity on CT scanning, you'll hear the term Hounsfield units. Now, CT scanning is excellent. MRI is maybe better. I would argue for brain tumor operations, an MRI is preferred. I don't want to diminish CT because I'm actually a big fan of CT. I think CT is better at showing you blood. MR can show you blood, but it's much more confusing. CT is much easier to obtain, especially in Canada. And CT is quite good for following somebody in a serial fashion on short notice. So they both have their advantages. But MRI, certainly for planning a surgical procedure, a brain tumor operation, is pretty much required now. And you can see the development of MRI and the different individuals involved. Percival and the nuclear magnetic resonance phenomenon, but Lauterbur and Mansfield get most of the credit for transforming the MR phenomenon into MR imaging. And once again, because of the revolutionary nature of this work, this led to them receiving Nobel Prizes. So what about combining surgery and chemotherapy? This is a more recent development, probably in the last 50 years. When I was going through residency, this was relatively new. Something called Gliadil, trade name, but really properly called BCNU wafers. This is basically putting chemotherapy agents into wafers that dissolve slowly in the tumor cavity. It showed some promise initially, but unfortunately not really enough to warrant its high cost. It's still used in the United States, but not really used much in Canada. There were other sort of technologies worked on to try and improve upon the BCNU wafers, but nothing really panned out to be revolutionary, let's put it that way. So what are the limitations of surgery? I mean, it's nice to be able to take out a brain tumor and improve somebody's scan, but really the biology of the tumor is ultimately what determines the patient's outcome. Surgery is very important in the treatment of patients with brain tumors because there's nothing that can really remove a lot of tumor quickly, as well as an operation can. So the problem is that malignant tumors are all infiltrative. And you'll hear terms like maximal resection and more is better, and that's all pretty much true. There's pretty good evidence now to show that if you can remove more tumor, that's better for a patient. However, as a surgeon, you will never be able to cure a patient with a malignant tumor with an operation. And the best example of this is an individual by the name of Walter Dandy, who is a pupil of Cushing. Some say that Dandy was actually technically better than Cushing. Hard to know, wasn't there, but Dandy was quite aggressive and performed hemispherectomy for glioma in a patient. And despite taking out the whole hemisphere of the patient, the tumor recurred on the opposite side of the brain anyway. So as a surgeon, you can do a lot, but you're not going to cure a patient with a malignant tumor. Now, it's different for patients with benign tumors. So meningioma is the most common tumor in an adult. It's a benign tumor. And for those patients that need surgery for their meningioma, a surgeon can pretty much do a curative procedure if the meningioma is in an optimal location. Now, I mentioned I would talk about some stuff outside of surgery. And earlier I mentioned Dr. McDonald, David McDonald. Historically, there was very few chemotherapy options for patients with brain tumors. But as I mentioned, Dr. Cairncross and Dr. McDonald basically looked at a group of patients with recurrent anaplastic oligodendroglioma. This is an example of keeping track of the patients you look after and documenting their clinical care, basically. So all research doesn't have to be done in the lab. Clinical trials, even if they're small, can start you off on the right foot. And what they did was they took these patients in their clinics with recurrent anaplastic oligodendroglioma and tried this treatment regimen called PCV, procarbazine, CCNU, and vincristine. And they found that 8 out of their 8 patients responded. And I think they were actually quite surprised. And when I spoken to Dr. McDonald about this, I said, well, how did you guys know these patients were going to respond? And he said, we didn't know, but they did. And we kept their tissue and we kept track of them. And ultimately, the tissue was sent for analysis. And this eventually led to the identification of the 1p19q co-deletion in those tumors. As well, because of this response, a trial outside of the local institution was also instituted called RTOG 9402. And so that's anaplastic oligodendroglioma. What about glioblastoma? It's the most malignant of the glial brain tumors. And this trial in the New England Journal of Medicine that was published in 2005 was the first to show that some patients with glioblastoma can respond to treatment. And this is temozolomide and radiation therapy. And what you'll find is that this is referred to as the Stupp protocol, named after the lead author. But there are authors on this paper, a fair number actually, from Canada. Warren Mason, the second author, is a neuro-oncologist in Toronto. And Barb Fisher, who I think is 4th or 5th on that list, is a radiation oncologist where I work. A very good trial from Europe and Canada. So that's a bit of the background for neuro-oncology and surgical neuro-oncology. What about now? So let's assume you guys all get into neurosurgery. As I said, I'm sure most of you have done electives and selectives or whatever, so you kind of have an idea. What I thought I would do is show you how we approach a brain tumor using example of low-grade glioma. So I will use the treatment options for low-grade glioma as an example of the decision-making process that we use to decide how to treat brain tumor patients, and maybe also use it to show you how treatment recommendations evolve over time. So as a surgeon, as a resident, and as a surgeon, really you're always trying to figure out whether you need to operate on somebody or not. I mean, most people go into surgical specialties because they like to operate, and sometimes the best treatment for a patient is actually not to operate on them. And as a surgeon, you have to make that determination. So for many years, and still today, there is some feeling that low-grade gliomas can be observed. So we call that serial interval imaging. But if you're going to do interval imaging, at what intervals should you do that? And that's what's been difficult. So there's really no specific recommendations. And often the neuro-oncologist is the one that's involved to making that decision along with you. And it will sometimes depend on the appearance of the tumor at the time of detection and the location of the tumor. So some recommend short interval imaging every 1 to 2 months, then extending the intervals to longer, 6 to 12 months. However, you need to make sure that you check the overall change in the tumor size if you're going to be following a patient with a low-grade tumor over many years, not just between the most recent 2 scans. So this is some work that we did where I am in London. The people that were mostly involved were Chloe Gooey, who's a neurosurgery resident now at the University of Toronto, and Dr. John Lau, who's the newest staff neurosurgeon where I work in London. And they basically showed that these low-grade gliomas gradually increase in size over time, and as we would predict. But it can be very subtle, because when the neuroradiologists review imaging, they generally just compare to the most recent scan. And this is a figure from one of the papers that Chloe published. And you can see what she did was she looked at the scan at each sort of yearly interval. You can see the time there over months, and the descriptor that the neuroradiologist used. And when they would just compare to the last scan, they would say no significant interval, unchanged, unchanged. And yet clearly when you go from the bottom there to the top, this lesion is increasing. So you have to be vigilant. Ultimately, as the neuro-oncologist or the neurosurgeon or the neuro team, you need to be aware that these tumors are growing. Now, the next thing to really discuss is extent of resection. And there's always been a little bit of controversy, uncertainty around how important it is to resect. The current feeling, though, is that the more the better. There are some trials that are reasonably well done that support that. I don't think you're ever going to get a truly blinded, randomized trial. You just really have to go by these series that people have done over the years. One of the better studies, though, that favors earlier intervention and more aggressive management of low-grade tumors is this paper in JAMA from 2012, and it's a Scandinavian study. And basically, it's somewhat like Canada. People generally, patients in Scandinavian countries generally follow the advice of their managing physician. They don't really go look for second opinions so much. So really what this group did was they looked at two separate hospitals. At one hospital, the oncology team would recommend watchful waiting and biopsy and watchful waiting, and the other hospital would recommend resection. So hospital A was biopsy and watchful waiting preferred, and hospital B was resection preferred. And they followed a number of these patients and basically showed that in the hospital where early resections were performed, those patients generally did better. Now there are some weaknesses in this trial, but it certainly suggests that earlier intervention is probably better if it's feasible. Now, this is a paper that came out in the Canadian Journal of Neurologic Sciences. And basically what they did was they surveyed Canadian neurosurgeons to see how they felt about managing low-grade gliomas. And they basically found, they presented 3 cases to the neurosurgeons to see whether they would watch, whether they would biopsy, or whether they would try to do resection. And they were of different difficulties, the cases. And basically they found that there's an overall trend now in Canada to more aggressive surgical resections. And surgeons are factoring in trial results. And so I think this is a general trend, not only in Canada, but in other countries as well. So if you're going to do an operation, what kind of operation would you do for a patient with a low-grade tumor? So really it boils down to, are you going to do a biopsy or a partial resection or attempt a gross total resection? Once again, we talked about anatomy at the beginning. Obviously, if you're going to consider a gross total resection, you need to be aware of where you are and what harm you can cause a patient. Most of these patients with low-grade tumors present with symptoms that are not that severe and that often can be managed. Seizures are really the main symptom they present with. Most of them can be controlled with anticonvulsants. So if you're going to attempt a gross total resection, you need to be aware that you could cause the patient harm. So there are times when doing a biopsy is probably the better option than doing a bigger resection. However, if the lesion is in an accessible area, then one can argue that doing a lobectomy, so resecting the right frontal lobe, is a relatively safe thing to do. So if a patient has a right frontal, polar lesion, taking that lobe out is certainly worth considering. Another thing that I tell our residents is that there may be a false plane of demarcation between the tumor and what appears to be normal brain. Low-grade gliomas can do this at times, and it's not too hard to start to follow this plane that you think is there and then wander into normal brain. And then we talked about the impact on progression-free survival and overall survival. So if you've decided to do an operation on a patient, what are some of the adjuncts that you can use to improve the chance that you're going to get a good surgical result? So I'm a proponent of functional MRI and tractography. At our center, we've had pretty good access over the years to preoperative functional imaging. So this is a case where a person's got a lesion that's close to their motor area or their speech area. And if you can preoperatively map out the relative position of the lesion, the tracts involved with that, it can help you plan your surgery and your trajectory towards a tumor. Spectroscopy can be of some help. It's more useful in trying to distinguish tumor from non-tumor. We mentioned earlier awake craniotomy in Penfield. Where I work, it's a very proactive awake craniotomy center. So there'll be weeks where I'm doing one or more awake craniotomies. Once again, this is especially important for patients that have a lesion near the motor area or the speech area. And stimulation can be done cortically or deep. You know, we're also a very strong epilepsy center where I am, and they do a lot of the stimulation for those cases as well. We've already talked about the operating microscope. Another tool is the ultrasonic aspirator. So for those of you that have been in the OR, you've probably seen things called Cavitron or Sonopet. These basically break up the tissue and then suction it up. It's very tempting to use the ultrasonic aspirator once you start using it, and it's pretty easy to suck up the tumor. I will give you a word of advice. Make sure that you don't suck it all up. Make sure you get some pieces for the pathologist and sometimes for research purposes. It's fun to use the Cavitron or the Sonopet, but make sure you save some tissue. Image guidance, you guys probably have seen that in action. The other term for that is neuronavigation. So to me, this probably is the next most important development for brain tumor surgery, maybe after the operating microscope. Prior to neuronavigation, it was a bit of a, you know, your craniotomies were bigger, cases took longer. With neuronavigation now, you can pretty confidently find a lesion, even if it's below the surface. And then intraoperative MRI, not quite as big a deal as people thought it would be, quite costly, and probably hasn't really changed management that much. But that's debatable, I suppose. Not everybody has it, obviously. I mean, it's hard enough to get a diagnostic MRI in most Canadian institutions now, let alone have an MRI machine just being used for surgery. So here are some pictures of those devices for those of you who may not have seen them. On the left there is an image guidance machine. This one's called Stealth. That's an operating microscope. That's a Zeiss, I believe. And then one of the devices that's used for stimulation. There's an ultrasonic aspirator there. As I said, it desiccates the tissue and suctions it up. fMRI, so these are what some images of fMRI look like. This was a finger tapping test for a lesion that was below the motor area, and you can see the yellow shows where the brain activation occurred. And you know, I think it's kind of incumbent on you, if you're going to use fMRI, to verify with stimulation that what you're seeing on the fMRI is compatible with what you see intraoperatively. So we've done some stimulation tests with the fMRI imaging simultaneously visualized. So let's just walk through a low-grade glioma case that a neurosurgeon might get when they're on call or sent to clinic. This was a case that this was a patient of mine, a 44-year-old man. He was a policeman, right-handed. Most low-grade glioma patients are in their late 30s, 40s, maybe early 50s. Usually once you get above the age of 50, you're more concerned that a glioma is either, sort of a higher grade glioma, intermediate grade, sometimes we call them. 44 is a pretty typical age for a patient to present with a low-grade glioma. As I said, no significant past medical health, presented with focal and secondarily generalized seizure, started in the right foot, extended up the right leg and into the right arm. He had persistent weakness in the right leg, mild headache. And when you examine him in the merge or clinic, he's got mild weakness of the right leg. So this is the imaging. So this is MR imaging, and low-grade gliomas are generally hyperintense on T2 scanning. The other important thing is that they don't enhance. If a tumor enhances, it's highly unlikely that it's going to be a low-grade tumor. I think you guys had a talk by one of my colleagues, Sachin Pandey, Dr. Pandey, and him and I, that talk he gave, we kind of gave a version of that talk at the Canadian meeting last year. It's a very good talk that shows you the basics of radiology and what to look for in different kinds of tumors. But here you see an example of what looks like a low-grade glioma. So, as we talked about earlier, is this a lesion we should observe? Is this one that we should just biopsy? Is this one that we should resect? And you can see that it's on the left side of the brain, and it's not too far from the motor area. One could say, well, it's in front, but is it close by? That's one thing you'll find when you're a resident. It's going to be a lot of, is that in the motor area? Is that the knob there? Is that, it can be difficult to determine that kind of thing. So this is a case where I think functional MRI is helpful. So we did a functional MRI in the motor paradigm, the tapping paradigm that I showed you before. We saw a signal behind the tumor, but near the tumor, the posterior aspect of the tumor. Another thing that we use, and this is where we work closely with the neuro-oncologist, is to assess low-grade patients for risk factors. It's something called the Pignati criteria, and some of the neuro-oncologists are very fond of it. Basically looks at things like patient age, whether a patient is symptomatic, because it's not unusual for low-grade gliomas to be discovered asymptomatically, which is even more difficult. If the patient's fine, bumps their head and gets a scan, and they see an abnormality, and then it gets an MRI, and basically asymptomatic patient has a low-grade glioma. What do you do with those patients? But anyway, this patient obviously is symptomatic because they've had a seizure, and this would be considered a larger tumor because it's greater than 6 centimeters. So by the Pignati criteria, this tumor falls into the high-grade category for low-grade glioma, which does favor treatment. So after discussion with the oncology team, we decided that we should offer the patient treatment. Should we do a biopsy followed by radiation and chemotherapy, or should we do a surgical resection? So the options were discussed with the patient. We favored a surgical resection. No matter what you favor, you have to give the patient the options that are available. And if you favor one, which you probably will, as a surgeon, you generally will have something that you favor, and then you have to review them, the risks and benefits of that procedure with them. And then in this case, because it was close to the motor area, we discussed with them, should it be done under a general anesthetic versus awake craniotomy, also known as neuroleptic. Ultimately, the patient opted for an awake craniotomy neuroleptic procedure. You can see there what the brain looked like at the time of the operation. Often these low-grade gliomas are not clearly visible on the surface of the brain. They have a very similar appearance to the brain that surrounds them. The image guidance obviously helps. And there you can see the cavity after the resection. And the patient was quite good during the awake procedure, did all the things that we asked. So, the patient will be asked to move their fingers and so forth while you're doing the operation. And it's good to have a cooperative patient. You can see there that it was a reasonably good resection. So once again, you guys are all pretty keen on neurosurgery, so I'm sure you've seen how operations are done. I show this more for those who may not have. When I gave this talk in Ottawa, there were neurologists and so forth in the audience as well, and most of them try to avoid the OR. So I thought I would try to show how we do the procedure. As you guys, I'm sure, know, we place these fiducial markers on the head, and the patient gets an MRI scan, preferably, or a CT scan. If it's sometimes a CT scan can be as good or better, especially for bony lesions. And then the patient's head is put in the 3-point fixation known as Mayfield, one that we use anyway. There are other ones. Then you can see an old image guidance machine here. This is really an ancient one, but I have no problem showing it. Image guidance is a tool. Doesn't really matter all the bells and whistles that they have. Every company is going to try to. We're trialing some image guidance machines right now, and they're always trying to show us what color they can make the tumor and what lines they can put on it and all this kind of stuff, how many screens they have. Doesn't really matter. It's a tool, and as long as it's reliable and can get you to the tumor, that's the most important thing. So even an older machine like this is perfectly fine. And there you can see the lesion in the brain. And then you have to register the fiducials to the preoperative images, and that's Talal, one of our earlier residents, doing that. And image guidance is obviously important. I mean, you've exposed the cerebellum there. Where's the tumor? You don't want to just sort of randomly dig into there. With image guidance, you can follow the shortest distance and the safest trajectory and so forth. So there's the lesion being removed. So that's kind of what we do now. What's going to happen in the future? Some of this is kind of already here, what I'm going to show you. Some of this is pretty sure it's going to happen. Other things I'm going to describe is speculation, I guess. And I'm certainly not going to cover every possible thing. I've put things down that are maybe a little more documented. So many centers now are using something called 5-ALA, 5-aminolevulinic acid, and it's used as a fluorescence guidance agent in glioma surgery. It's really best for high-grade gliomas. That's where the evidence is. Now, it's been around for a while. It was developed in Germany almost a decade ago, or over a decade ago now, I guess. The person involved mostly is somebody, Walter Tumour, and we've had him here in Canada speak at our Canadian meeting. And basically what you do is you give the patient this agent, the 5-ALA, orally prior to the surgery. Using visible white light, you resect the bulk of the tumor that you can safely, and then you shine fluorescent light on the brain, and the residual tumor shows up different color, blue or pink, depending on what kind of filter you're using. And then you can resect the part that you didn't resect yet. It's been slow to be adopted in Canada, although most centers are using it now. I actually wrote this editorial a few years ago on why it was so slow to be adopted in Canada. And it's really involves regulatory hurdles at the FDA in the United States. In the US, the FDA considered this agent as a drug, and really it's just a fluorescent agent, but because it was considered a drug, it went slowly through the regulatory channels. But eventually it was approved. Canada usually follows the US when it comes to approving things. What's also slowed it down in Canada, though, has been the cost considerations initially, and the fact that you need a microscope with the proper filter on it. Many centers didn't have that. Basically had to get upgrades in their microscopy in order to use it. Ottawa has probably done the most work in this area. They've been using it for a number of years. Now, something else that I think is going to be used is intraoperative Raman spectroscopy, and Montreal has been heavily involved with this, as well as a number of centers in the US and some in Europe. The idea is that you get molecular specific information during the operation. So there's kind of like a probe that you can put on the tissue surrounding where you've resected, and you get real-time discriminatory feedback as to whether it's tumor that you've still got there. So in real time, you should be able to determine whether your resection should continue, as well as detecting blood vessels and so forth. Now, I mean, both 5-ALA and Raman don't take away the responsibility of the surgeon to make good clinical judgment intraoperatively. I mean, you know, if there's fluorescence, especially with the 5-ALA, you can't just go chasing it willy-nilly. I mean, if you're near the motor area or speech or something, you see fluorescence, but in your judgment, you're going to encroach upon functional tissue. You've got to hold off. I mean, you don't want to hurt patients. You know, despite the data that supports more thorough resections, there is also data that says patients don't do as well if you as a surgeon hurt them with your surgery. So you have to use good judgment. These are all just tools again. So you'll probably see different types of scopes during your residency. There's things called endoscopes, which are commonly used now for tumor surgery in the ventricle. And then skull-based tumors, some of them are being done with endoscopes depending on the center you work at. And then now there's these things called exoscopes where you can do surgery down the tube. So glioma surgery is being done in some places with these exoscopes. Surgery of insular glioma, since I showed you that case on low-grade glioma, I thought I would mention these more aggressive surgeries for gliomas that are in the insula. A lot of this work has been done in San Francisco. Mitchell Berger is the surgeon's name there. There's also another surgeon in France, Hughes Dufault, and they're quite strongly advocating for attempted resections of these insular gliomas. And they're showing that the surgery can be done with acceptable morbidity. But if you're going to attempt this kind of surgery, it goes back to the first slide, Vesalius and anatomy. You need to know which corridor you're going to go down, because, you know, once again, a lot of these patients are not that symptomatic, sometimes asymptomatic. And if you get lost down there, you can cause vascular injury, you can cause neural injury. So this kind of work has to be done carefully, arguably after a fellowship. So there's some of the publications from those authors. Another Canadian thing, Dr. Del Maestro in Montreal, he doesn't really operate now, but he does a lot of work in surgical simulation. He probably gave you some information about that when he gave his talk. This is preparing you for surgery. You'll find that during your residency, there's something called EPACE that you have to be able to do, demonstrating that you're competent in certain procedures, and simulators are one way that might help you to learn how to operate better. At the end of the day, though, surgery is really an apprenticeship. There's nothing like operating on a patient, you know, with the guidance of a neurosurgeon and getting confidence that way. The simulators are great. I don't think, though, their haptic feedback is as good as it could be. I think Dr. Del Maestro is working on that. But probably some combination of simulator and real life surgery is going to be in the future. Then there's this thing, case-based learning, that we've been working on. And what I might try and show you here is, if I can get this thing to work, I will try to switch over to this that I had here. So we've developed this case-based thing here in London. It's myself, a neuropathologist. Can you see that? You see a histology slide there? What we've developed is something called Med-CBL, Med and CBL, case-based learning. And it's free. You can access it on the internet quite easily. Dr. Hammond is a neuropathologist who's quite interested in resident teaching, as well as Dr. Lee Young, who's one of my colleagues in medical imaging, a neuroradiologist, and myself. We developed this module, and right now it's primarily around neurosurgical cases. So what you do is you go to this case index and you pick, we've got 100 neuro cases on here now. And basically you go to a case. So let's see what case 8 is. There's a very short history physical, 37-year-old right-handed female, headaches worsening over the past 4 months. So you want to take a look at the imaging. So there's a scan there, and I don't know, can you guys see that? Basically, what you have is a scan of the brain, MRI. So I don't know, does anybody want to, what do you see there? Are those ventricles normal looking?
Some pretty significant ventricular.
Yeah, I think there's hydrocephalus there, isn't it? And then there's something here that concerns me anyway. So you can speculate, you know, when you're studying as to what that might be, but if you're stuck, then you can go to the interpretation. So what we've put there is there's a small round lesion in the foramen of Monroe between the frontal horns. This is iso-intense to brain. So you can just slide this across here. And then what he's done is he's put the little star. If you don't see it, that's the where you want to be looking. So yeah, there's shows the large ventricles there, shows the lesion there. Once again, if you're having difficulty finding it, you just slide this across, and he's put the star right on it. High signal relative to CSF is from proteinaceous debris, so it helps you interpret it. Small vessels draped over the mass, so if you don't see those without the little helper thing here, you those are. So what was done? So this patient had an endoscopic resection of the third ventricular lesion. So what is the pathology? So you have a look at the pathology here. So what we tell you is this is an H&E, another H&E from different slices. So based on that, you kind of come up with a differential that you think histologically. If you're stuck, then you go to the interpretation. So proteinaceous acellular cyst contents, low columnar cyst lining, patchy expression of cytokeratins not shown. And there you go, colloid cyst. So pretty typical for a pretty typical neurosurgical case. Don't see a lot of them. Not all of them need surgery. Some can be quite indolent, small, but a very popular case for a neurosurgical quiz or exam. It's some typical histologic findings and pretty typical radiographic findings with hydrocephalus. So you can just skip right to the next case if you want. This is a 48-year-old right-handed female, right-sided facial pain. And then, move on to the radiology. So you get the idea. And you can also do it as there's a diagnostic index that will, if you're looking for specific cases, that will also help you define them. So, and we've broken it down: neoplastic, non-neoplastic, primary, secondary, and listed a bunch of different tumors there. So there's different ways to use this tool. So I encourage you, no matter what you go into, to have a look at it. Our hope is down the road to develop modules for different subspecialties. So we've already spoken to some of our colleagues in cardiac and thoracic and other specialties to try and make this more diverse. So let me see if I can go back to the presentation, if it will carry on. So case-based learning. So there's the website there. If you just put MedCBL into Google, amazingly it comes up first. I guess we picked a good word for it. Okay, now back to the speculation. So you guys know about artificial intelligence, you guys know about machine learning, and now we've got molecular diagnostics. Is it possible future scenario where a machine will interpret the neuroimaging and come up with the most likely diagnosis? Some of my neuroradiology colleagues are already feeling a little nervous about the ability of some of these programs to look at scans and then go back in their huge database and come up with the most likely diagnosis. Will robots be helping us in the operating room? I think that's probably the furthest thing away at this point in time. But I don't think a machine spitting out the molecular diagnosis is going to be that far away. So basically, we send a specimen now to the pathologist. We get a quick section, frozen section at the time of surgery. They speculate based on the histology what they think it is. But I mean, if the piece of tissue could be put in some device that could look at the molecular constitution of that tissue, they could probably tell us. Machine could probably tell us right away what the most likely diagnosis is. At the bottom, at the end of the day, will treatment and outcome be any better? That remains to be seen. I think we are getting better at diagnosing things. Not totally sure we're getting better at treating things yet. Now, I will quickly, in the last 20, 30 minutes, if you're still game, of the lessons I've learned over a number of years doing this business of neurosurgery. This will mostly be neuro-oncologic, although I will divert into some general neurosurgery concepts. What I'll try and do is let you guys know and help you gain an understanding of how research and teaching may be incorporated into an academic neurosurgical practice. Hopefully you'll gain an understanding of how knowledge of the literature is important, but personal experience is also important in guiding clinical neurosurgical patient care. And then maybe help you gain an understanding of how you as neurosurgeons can do things beyond the operating room. As a neurosurgeon, you'll love to operate, but you do have other responsibilities that can be also, pretty exciting and fun. So let's start with research, because that's the one that everybody likes to talk about. I find a lot of residents feel that they have their CV when they're applying for neurosurgery to be full of research things. It doesn't hurt, but at the end of the day, it's neurosurgery you're going to learn in residency. But I'll talk a little bit more about research here and some perspectives on it. So what I've put here, there's a truth. In neurosurgery, as well as other specialties, but especially in neurosurgery, you are always going to be busy looking after patients. Patient care, is your number one priority. That's your prime directive. But you can still do research. In fact, you can have a pretty good career doing research. But I think what you do is you have to strive for attainable goals. And I use one word there: collaborate. If you collaborate, you will probably be stronger. Back 50, 60 years ago, there was this idea that the surgeon could also be the scientist and do everything. I don't think that's really realistic now, and I'll say a bit more about that shortly. So I'll try to show you some personal examples of how we can collaborate with each other on research projects. As I said, I will cover different areas of neurosurgery, and this is going to go back a number of years. So this is a collaboration that we did between neuro-oncology, neuroradiology, and neurosurgery. And I mentioned Dr. Cairncross earlier and Dr. Lewis. They were involved with the 1P19Q and the underlying story. But what we also looked at, and myself and one of the residents at the time, Ed Catcher, he's now a neurosurgeon in Hamilton, we wanted to see if these molecular signatures would correlate with imaging, which was quite a novel idea at that time. And I mentioned the 1P19Q loss, and could this be sort of perceived on MRI imaging? So this was multi-center. It involved us in London, folks in Calgary, and the folks in Boston. It was retrospective. We got 40 patients with oligodendroglioma and looked at the different imaging characteristics on MRI with the help of expert neuroradiologists. I wanted to see if there was a correlation with the 1P19Q markers. So there's some of the figures from the paper. What we learned was that the loss of 1P and 19Q was associated with an indistinct border on T1 images, mixed signal intensity on T1 and T2, paramagnetic susceptibility effect, and calcification. Loss of 1P and 19Q was not associated with contrast enhancement, indistinct border on T2, and cortical involvement. So what? So did we contribute anything with this work? So obviously we didn't revolutionize brain tumor diagnosis, but it did play this. I think this paper did play a role in the development of what's now called radiomics, basically the extraction of large number of features from medical images using data characterization algorithms. And this is what I talked about a few minutes ago about artificial intelligence being as good or maybe even better than neuroradiologists at interpreting imaging. My caution will be, though, that you can't really talk to a machine, but you certainly can talk to a neuroradiologist. And some of the neuroradiologists are my closest colleagues, maybe even closer than my neurosurgical colleagues. You know, when you do brain tumor or aneurysms or whatever, you have to work with a radiologist. So, you know, I encourage you at the beginning of your residency, seek out the neuroradiologists and get to know them. They can be a very strong ally whenever you're doing clinical work. Now, this is a collaboration between the neuro-ICU people in rehab medicine, and us in neurosurgery. And basically, we were looking at what are the non-pharmacologic interventions used in the acute setting to manage elevated ICP and acquired brain injury. Pharmacologic interventions used in the brain injury to manage ICP, and techniques used to promote arousal from coma following an acquired brain injury. A lot of this stuff that you're going to see was being done, but it really hadn't been studied. And so we worked with a couple of groups, a group in Ottawa, a group in Detroit, and basically we looked at multiple databases, searched articles from the years that you see there. And we had a pretty good epidemiology person working with us who scored these trials. And then levels of evidence were assigned and recommendations were made. And you can see this is a figure from one of the three papers, and basically showing what we're doing does have some scientific basis behind it. And basically it said that there's level 2 evidence that raising the head of the bed does help. Kind of something we just assumed helped, but the data supports it. And you can see the different ones there. So did we contribute by doing this sort of exhaustive review of the literature? It really showed that, at least for me personally, I was confident in that what we were doing wasn't just something that was handed down from the people that trained me, but that there was literature supporting it. And this certainly, meta-analysis of data has become very routine now. we did it, it was relatively early, but with the faster, ability to probe into databases, there are many of these meta-analyses coming out now. This is a paper that we did working with a basic scientist, Robert Bartha, and one of my neuro-oncology colleagues, Dr. Watling, and this goes back to the interest I have in low-grade glioma. And Rob Bartha was very interested in MR spectroscopy and sodium imaging. And really, we were looking at the metabolic profile of low-grade glioma. Is there a correlation between metabolic levels using short echo time? And you can see there with the sodium signal intensity. It was a prospective trial. It was just done in our institution. And there's a figure from the figure from the paper. And basically what we showed was there's a significant decrease in sodium, in N-acetyl aspartate and glutamate, increase in acetylcholine and sodium signal intensity. And the most significant indicators of pathologic tissue in low-grade glioma was the NAA to sodium ratio and the NAA to inositol ratio. So this really, at the time, was also, like the 1p19q work, early work in the characterization of brain tumors. And is there a practical use for this? It kind of goes to trying to differentiate recurrent tumor from radiation or treatment effect. You still pretty much need pathology to do that, but at least you get an idea of whether you're dealing with recurrent tumor or treatment. I always liked this paper. It was a small one that we did, Rob Hammond and I did with a medical student and a graduate student and a neuropathology resident. And what Rob was really interested in was, can we optimize intraoperative neuropathology consultations? And what are the sources of error when we're looking at quick sections and frozen sections? And what about experience? Does that help? Once again, this was a single institution study. What Rob looked at was his first 100 cases, and many of those cases were mine. His second 100 cases, more of those cases were mine. In his most recent cases, he used the final diagnosis as gold standard, and he classified errors as either minor or major. And then those that ultimately he called incorrect, he wanted to see, was that a sampling error, was that a technical error, or was that an interpretive error? Busy diagram. But basically what we learned, that first 300 cases, there were 22 errors. 11 were from his first 100 cases, 9 were from the second 100 cases, and only 2 from the last 100 cases. Sampling error was the main, was the number one cause, slightly higher than his interpretive errors. So definitely he felt that there was improvement in his ability to interpret cases as he got more experience. So what does this, does this kind of stuff contribute? Well, it does in a way. It doesn't shake the world, but you do need to examine your own practice and reflect on your own practice and get a better understanding of it. And regulatory boards are demanding this now. Quality improvement. And our college here in Ontario, the CPSO, is now requiring us to analyze our own practice and to see if we're meeting standards, certain standards. And for me, this was a good project because one of our neurosurgery residents got interested in this and ultimately did his master's looking at more detailed aspects of this. What about just alone as a neurosurgeon? Can you do something? Well, you can. This was an interesting paper that I did. Unstable internet. Question we were asking: what suturing technique provides the most watertight dural closure? Does fibrin glue improve the integrity of dural closures? Because different people use different techniques to close the dura when they're finishing their operation. And we did a prospective trial. Dr. Del Maestro was involved with this one, where we did locked sutures, simple sutures, unlocked sutures, vertical mattress sutures, and basically developed this sort of simulation of a dural closure. And you can see there's a dural membrane here, and incision is made and then sutured, and then pressure is imparted on the device to see which suture type holds the best. And you can see some patches there as well. So what we learned from this, at least in our trial, in vitro trial, was interrupted simple suturing technique provides the most watertight closure for linear incisions. And then we also tested fibrin glue, and that does improve the closure. So, as I said, this is the kind of trial that, as a neurosurgeon, you can do on your own. To get if you develop a little device with a technologist or something, and you can do it in a short research block. 2 of our residents were involved in basically, I think, 2-month blocks. I'm not sure that my colleagues really changed their technique based on this. Certainly, I use the interrupted sutures now. The folks in Toronto like this trial because that's the way they close it. So I think it's supported what they do there. So well, people always like that when a trial shows that what they're doing is good. I encourage you to do case reports. That's something that when you're in your first, second year, you should have time to do 1 or 2 case reports. You always learn more about a case when you look into it a bit and write it up and present it. And review articles, interestingly, are probably the most cited papers if they're good. You can do it as a medical student. Residents can do them. Grad student can do them. This is one that a grad student that Rob and I were supervising did on tissue culture. And I'm involved with the editorial board of the Canadian Journal of Neurologic Sciences, and the CJNS wants these articles. So if you come up with a good topic and find a supervisor to help you along, there's a pretty good chance that if you write it up, it'll get published somewhere. Now, I just want to touch on teaching and education. Once again, we're all busy. Do we have time to teach once you're finished as a neurosurgeon? So it's desirable to teach medical students, residents, and fellows. And teaching should be fun, but sometimes it can be stressful, especially teaching people how to operate in the operating room. You can contribute to education at all levels, and I'll show you an example of that. And then once again, you've heard this expression, learning is lifelong, and that's definitely true. I'm still learning, probably so much to learn. And you can learn from colleagues, you can learn from fellows, always can learn, never ends. So once again, some personal examples. University-based teaching. So I teach medical students. In fact, tomorrow, first thing I'm doing is teaching what's called clinical methods to the medical students, the neurologic exam and so forth. Small group teaching I'll be doing later in December. Teaching residents how to operate, that's probably the prime directive you have as a neurosurgeon if you work in an academic center. That's not as easy as it sounds. Giving person more responsibility as they move along can be very challenging, but it's got to be done. What's probably harder in some ways is teaching residents how to make decisions. So in the clinic, the operating room, in the emergency or on call. Residents all like to learn how to operate. Not always do they like the decision-making part, going to the clinics and being on call. But at the end of the day, you've got to learn when to operate, when not to operate, who to admit, who not to admit. All that is extremely important. What about teaching fellows? I've had a number of fellows over the years. That the challenge there is, are you trying to teach a fellow to operate how you do it, how to make decisions how you do? It's kind of a two-way street with a fellow because they've often trained elsewhere and they can bring things along that you don't even know about. So fellow teaching is quite interesting, actually. I'm heavily involved with CPD, Continuing Professional Development, or CME. This is providing teaching opportunities to colleagues in your own institution or elsewhere. It's often cross-disciplinary, so we've put on some courses over the years, in person and online. with neurology and neurosurgery, since we're a combined department at Western. And most of them now, of course, are online webinars. I mentioned the MedCBL already. I'm involved with the Ottawa Neurosurgery Review course. So most of you, towards the end of residency, will take this course that's in Ottawa. The Canadian Neurological Sciences Federation was mentioned at the beginning. I've really been heavily involved with that for the last decade. It's an organization that combines the neuroscience specialties. So there's different societies. The Canadian Neurosurgical Society is one of the founding members, but there's also neurology, child neurology, clinical neurophysiology, stroke. Most recent one is stroke and neuroradiology are the most recent ones. So how can you get involved with the Canadian meeting or the Canadian Neurological Sciences Federation? So you can present at the Canadian meeting, which is the National Congress this year or next year. It's going to be held in Toronto, and it's, I've noticed, the 100th anniversary of neurosurgery in Canada and Toronto/Toronto. So there's going to be a very strong neurosurgical component to the Toronto meeting in 2024. You can speak or be a chairperson at the Canadian meeting. And then there's different committees at the CNSF. I've been involved with the Professional Development Committee in the past. As was mentioned, I'm now involved with the Scientific Program Committee. And as I said, Canadian Neurosurgical Society, which you become members of as residents, is part of the CNSF. Now, the Royal College is something you'll need to know about, in neurosurgery or whatever specialty you choose to go into, if not neurosurgery. It's the Canadian organization that's charged with advancing the learning for specialist physicians to deliver the best healthcare for the population. Most physicians kind of have a love-hate relationship with the Royal College. It is the body that certifies them, but then it requires them to demonstrate competence and continuous learning. There are lots of committees that you can get involved with. There's the Neurosurgical Specialty Committee, Resident Program Committee, CPD committees, which I've been involved with. It's actually a lot of work. The Royal College can be a lot of work, but it's quite rewarding. So as a practicing physician, the Royal College will involve you. How much you want to be involved with the Royal College is up to you. I mentioned mentoring. So Dr. Del Maestro there, a picture of him again, one of my mentors when I first started. There's our annual baseball game between neurology and neurosurgery here in London, and some of the people there are individuals that I have mentored. I've mentored at all levels, medical students. As a neurosurgeon, you can have a pretty great influence on medical students' life. I'm pretty sure I've had the effect of causing one or more to go into neurosurgery. I say for better or worse. I think for the better for the ones that I can put my finger on. But residents, there's formal and informal mentoring. And at Western, we each have a resident that we formally mentor, and then I've informally mentored a number over the years. 2 or 3 of those I can say have gone into surgical neuro-oncology, I think partly because of that mentoring. And then fellows, I've worked with a number of fellows. We just had one who's in Jordan come back here for a visit and had dinner with him. So these lifelong things, mentoring. There's a number of the residents that I've crossed paths with. Now, prime directive, I've mentioned it before, is clinical patient care. Teaching is important, research is important, but doing a good job looking after your patients is probably the most important thing. What lessons have I learned? We're all busy. We should use the literature to help guide our clinical decision making, but common sense and experience also count for something. You should work with all of your colleagues. When you're finished in your neurosurgery, you've got to work with colleagues. Help them when they need you, because you will almost certainly need to get help from them. And I'm talking about intraoperative help. I'm talking about taking call for a colleague, helping them when, they've got a sick kid and they've got to be away and cover them, that kind of thing. And as a surgeon, as a physician in general, but as a surgeon especially, you have to admit your failings to the point that it hurts. This is a sort of a quote attributed to Dr. Drake. And you must learn from your shortcomings. So you can't hide from your mistakes. You will, not all your patients will do well, but you can't hide from the patients that don't do well. You have to learn from any error that might have occurred. So let me try to illustrate this with a case that we had a year or two ago. We showed this at the Canadian meeting in Banff last year. So this is a 57-year-old man who presented to the Emerge. He had a 1-week history of headaches. He woke up with severe headache, nausea, and vomiting, presented to the Emerge with left gaze deviation, left arm shaking, followed by a general tonic-clonic seizure. There's his past history. So what about the immediate management? How would you, where would you localize this? Well, headaches are pretty vague. What's the differential diagnosis? What are the next steps? These are the kind of questions you're asking yourself as you make your way down to the Emerge. What am I going to do? Where's the abnormality? What are the possibilities? So had this imaging done, and you can see it's a bit of an angry brain, but probably the most obvious thing, I think you can see this. I say obvious, but it's not that big. It's this little area here and a little bit of engorgement and stuff. Blood work there shows an elevated white count. Otherwise, his blood work was normal. But what is this? Well, this was felt to most likely be an infection. Subdural empyema was thrown out as the thing. Went on to have an MRI, and that seemed to confirm that. You can see there looks like there's a sinus infection here in this little area of dural enhancement and maybe a little bit of a collection here. So what to do? So diffusion weighted imaging was a bit more concerning, but we looked at the literature and it basically said that small subdural empyemas could be watched. And that's what we decided to do. Not do surgical intervention, treat the patient with antibiotics. We got ENT involved because if you have an infection, you always want source control. And they did a sinusectomy. They basically accentuated the sinus. But the patient didn't really do that well. They were watched in the ICU. They were obeying. And the cultures from the operating room grew the organisms that you see there. So even though he was being watched in ICU, he was still neurologically quite well, obeying strong by 4 normal cranial nerves. But unfortunately, his imaging deteriorated. And you can see there that now there's more of a cerebritis here. And this is 7 days after he had the sinus resection done. So we operated on him and did what we thought was a pretty good resection of this area and empyema. Unfortunately, he declined. You can see, I won't go through all the elements of his course, but he had a worsening left-sided weakness, persistent recurrent infection in the resection cavity with surrounding edema and necrosis. This was despite being on maximal antibiotics and the resection that we had done. So then 33 days after he first came in, it's deteriorated even further. And you can see that his brain is now swollen and this cavity is still very angry. And he's basically hemiplegic on the left side. 3 neurosurgeons were involved with this case. I was the first one. Then I had to go away. I think I went to a conference/vacation. And one of my colleagues was involved with the second operation. and now the third neurosurgeon was involved, and he went and basically had to do a large cortical resection in this patient who had basically come in with this smallish subdural empyema and sinus infection. So there's the course in hospital. He actually, the patient's Glasgow coma score improved from a comatose state. Obviously, he remained hemiplegic and had a cranioplasty after 4 months. So this was a very disturbing case, I think, especially for me, who had been initially involved with the patient. And I had to ask myself, should we have done something at the very beginning? Should we have done a craniotomy and done surgery on this right away? Was there adequate source control at the beginning? Should the patient have been on wider spectrum of antibiotics? We had discussion with ID about that. And should there have been a greater extent of the necrotic tissue, the operation that he had for the cerebritis, done by one of my other colleagues? When we showed this at the Canadian meeting, of course, there was different opinions. Some said they would have operated right at the beginning. Others said they weren't sure they would have. Interestingly, some even weren't sure they would have operated at this point because they knew they were going to leave the patient with a permanent deficit. They wouldn't have done that procedure and the patient would have died. So this case had some ethical issues around it, some decision-making issues around it. But this is the kind of thing that during your residency and your career as a neurosurgeon, you will struggle with. Should I have done something? Should I have done something better? Would I do it differently the next time? Now, the final thing, as I mentioned, are there roles for clinicians and neurosurgeons in particular beyond the research, teaching, patient care? So there is this idea that as physicians, really, we should go in, do our thing, and go home. But the truth is that patients and their families want us to take a role in providing them support and helping to educate them on their disease and helping to explain to them what research is being done. Because they know about research. Many patients want to support research, but they don't really understand it. So they look to us for education, support, and helping them understand things. And the organizations that do this are usually foundations, often charitable, and they want us to help them. And the one that I've been involved with is called Brain Tumor Foundation of Canada. As I mentioned, Dr. Del Maestro was one of the co-founders, along with his wife, who's a nurse, and a patient that he had looked after. And basically, it's a nonprofit organization. It provides education, support, and research. That's an old figure there, the amount of money that's been raised, but and I'm the past chairman now. So what are some of the things provided? So we have this handbook that is available to anybody. We send it to centers across Canada and in other countries. It's been translated, and I think into 3 languages now. And there's also a pediatric storybook. I use the handbook when I talk to a patient. There's actually a portion of the handbook that you can write things down in it. So when I go over a patient's tumor with them, I give them the differential diagnosis, I write it down. I write down treatment options, and I write down risks and benefits in the book, so they have all that information. Some patients are not ready to make a decision when they see you in clinic, but having the book and what you've written down for them when they go home can be quite helpful. I mentioned support, so there are support groups across Canada for both adults and pediatric patients, and I've attended some of these support groups, and they really like to hear clinicians talk to them about different aspects of tumors and treatment. And then the Brain Tumor Foundation is also involved with research. As I mentioned, a fair bit of money's been raised for that. This can be basic science or clinical research, grants. We funded fellows. We funded fellows that are interested in surgical neuro-oncology in the past, as well as students. The Brain Tumor Foundation founded the Brain Tumor Tissue Bank that's located here in London, and we've distributed brain tumor tissue globally. You can see a number of countries there that have been sent tissue from our bank. We've also developed the Brain Tumor Registry of Canada. This is one that I'm particularly fond of because when I was the chair, myself and the executive director basically came up with the idea that we needed to have our own data in Canada. Most neurosurgeons and oncologists in Canada had been using the CB Trust, which is the American brain tumor database. So we, along with an epidemiologist who actually had worked on CB Trust and was living in Canada, went to the different provinces, and we now have a Canadian brain tumor registry. You can see the website there. And finally, there's more to life than just work. Family, friends, activities, hobbies, these are all important. Have to have fun. I've done a lot of traveling. I kind of travel with the Brain Tumor Foundation in mind. So this is a trek I did to the summit of Mount Kilimanjaro, I guess more than 15 years ago now, and some of the wildlife around Kilimanjaro. And there's that thing I'm holding is a Brain Tumor Foundation of Canada banner. Went to New Zealand, had something called the Milford Track, which is supposed to be the best kind of walk that you can do. Certainly impressive. I always wanted to see Machu Picchu, so we did the Inca Trail in Peru. Another really good trip. And then you guys put my picture on the notice for this talk. Thanks, that was nice of you. This is the Mount Everest Base Camp in Nepal with the Brain Tumor Foundation banner there. So hopefully you guys will all get into neurosurgery, and hopefully you guys will all have fun doing it. I've gone on way too long, but any comments? Happy to discuss anything you want.
Thank you so much, Dr. Megyesi. That was a fantastic talk and very multidimensional. The floor is open, of course, to questions. I have one question, but I'll wait to see if our audience has questions. And maybe we can keep them brief, because also I'm sure Dr. Megyesi might have other things to do tomorrow teaching, but we'll entertain a few questions.
Well, my lecture is ready. I've learned you have to be prepared, so I can go on if you guys want, whatever you want.
Thank you.
Practical questions about how to get into neurosurgery, I'm quite happy to ask those. You can ask me theoretical questions, whatever you want.
Of course, Abrar, please go ahead.
Thanks. Can everyone hear me? Terrific. Hi, Dr. Megyesi. I'm all right, sir. How are you?
I'm okay. Got your paper sitting here beside me too.
Thank you. So thanks for the talk. You spoke a lot about the use of artificial intelligence in neuro-oncology as well as neurosurgery, as well as its benefits. I was wondering if you had some thoughts about the ethical concerns, if there are any, with the use of artificial intelligence, and how and what your opinion was about mitigating those concerns.
So give me an example of what you would consider an ethical concern, and I can maybe be more precise in my answer.
I think generally speaking, one of the things that's brought up often by patients is the, I guess, the automation of medical care, the removal of that human aspect from medicine as a whole.
So my response then would be, like everything, artificial intelligence, image guidance, they're all tools. And I think whatever tools you can use to come up with a better diagnosis, a better treatment, are all important. But nothing is more important than talking to the patients. I mean, for brain tumor patients, I probably spend 30, 60 minutes with them in the clinic, which sounds amazing, I guess, for a surgical specialty. I mean, most neurologic disorders are quite concerning to patients, devastating sometimes. And the best way to calm patients and to reassure them is to talk to them at the beginning, I think. I think the thing that can really keep you out of trouble as a surgeon is making sure that you've developed a rapport with the patient and their family, making sure that you've described to them risks and benefits of your treatment in plain terms. So I try to use simple words like, you might be weak, you might not be able to move your hand. I don't say you might develop a hematoma. You might get an infarction. These are things that are correct, but they're not as relatable. My point is that you always want to have that human factor involved. Artificial intelligence, machine learning, all these things I think will help, but they're never going to replace that one-on-one contact. In fact, the COVID thing was very disrupting to a lot of us, especially me. I never really related to the virtual interviews. I would try to see patients masked up and everything. I preferred that to the virtual thing. And I've rarely done a virtual interview with a patient. So I'm very much person to person.
Thank you.
Dr. Megyesi, I had a question too. Sorry,
Sure.
My setup is different because someone kicked me out of the room. So I'm here outside the one of the questions I have for you is how promising do you find CAR T therapy for GBM treatments, maybe 10 years down the line? Do you think that's going to have
there was a bit of an echo, so maybe you could
I apologize. I can repeat the question, sure.
Sure.
What do you think CAR T therapy, chimeric antigen receptor T cells, what do you think they have for the prospect of GBM treatment in the next 10 years, 10, 20 years?
So there's been a bit of a undulation in my experience with it. Having I go to most of the neuro-oncology meetings, Society for Neuro-oncology, our Canadian meeting, the European meeting. So I would say that CAR T was quite big about 5-6 years ago, pre-pandemic. And certainly conceptually, it seems to hold promise. However, some of the trials that have been done have not been quite as successful, I guess, as was hoped. So I think the simple answer is I don't know. It might play a role, but I don't think it's not imminent, if that's the better word. There are some pharmacologic treatments for low grade that have some hope. Something called the Indigo trial, which was shown at the last SNO meeting in Vancouver. That I think might impact low-grade glioma management, somewhat like temozolomide had some impact on glioblastoma treatment. But apart from that, I don't really see any thing in the near future that will change high-grade glioma treatment. Fortunately, it's a very difficult field. It's a very difficult field.
Any more questions to Dr. Megyesi? If not, I guess no more questions. Thank you so much, Dr. Megyesi, for delivering this sort of tour de force of history and modern and future, and really appreciate that you could join us at Campsite.
Great. Well, thanks for having me.
Thank you again.